We'll start. Yeah. So, very good afternoon to everyone. Welcome back to the Climb India Journal Club. So, these webinars in Journal Club are hosted as a part of our Center for Advanced Research project studying the impact of climate change in brain infections. So, as a part of this, we have two flagship themes. One is the Let's Talk Brain Infections and Let's Talk Climate. And as a part of Let's Talk Brain Infections, we are hosting a series of webinars in Journal Club. It's an educational initiative to increase awareness and knowledge on the common brain infections as well as the uncommon ones. So it's also important to review evidence and see whatever practice we're doing every day. Is it based on evidence or it's more an experience-based treatment? So here we have AIIMS Delhi team led by Dr. Divyani, who's assistant professor in neurology at AIIMS Delhi, who will be moderating this session on this important article which was published in the Lancet Neurology, studying the safety and efficacy of adjunct dexamethasone in adults with HSV in UK. It's the DEXENCEPH trial. So this will be presented by Dr. Trupti KM, who's a senior resident in the Department of Neurology. We hand over the floor to Dr. Divyani for moderation.
Thank you very much, Angel. So for this journal club, just as an introduction, I wanted to speak about why we thought that this was an important study to look at. So herpes encephalitis continues to be a problem, significant problem for us. And unfortunately, it's one of those encephalitis that tends to leave behind significant sequelae. So we always try to look at what else can we do. And one of the approaches that has been looked at and where there is clinical equipoise is the role of steroids. And we do know that some of these patients can have a lot of edema, but even other than edema, whether steroids actually have any role in the treatment apart from our usual acyclovir. So this is one of, I would say that there are very few evidence-based studies on this, particularly randomized trials. In fact, this is the second one. So we thought that this was an important article to pick out. So with that, I would also like to introduce Trupti, who is going to be presenting the journal article along with the critical appraisal. She's a senior resident at our department and she will now be presenting. So Trupti, please go ahead.
Yes, ma'am. Good evening, respected faculty. At first, I would like to thank Climb India team and my moderator, Dr. Divyani ma'am, for this opportunity to present this important article today. Today, we are going to discuss this article titled Safety and Efficacy of Adjacent Dexamethasone in Adults with Herpes Simplex Virus Encephalitis in the UK. It is called DEXENCEPH trial. It is a multi-center, observer-blind, randomized phase 3 control trial. This was published in Lancet Neurology in Feb 2026. So coming to introduction, herpes simplex virus encephalitis is the commonest sporadic viral encephalitis. The annual incidence worldwide is 1 in 2.5 to 5 lakh population. It also causes significant neurocognitive sequelae, as ma'am told, and the most common sequelae is impaired verbal memory. This reflects the virus's predilection for temporal lobes in particular. The known treatment until now is acyclovir, which reduced mortality from approximately 70% in pre-acyclovir era to 5.5 to 12%. However, the morbidity continues to stay. All of them have long-term disability and less than 20% of patients return to work and they have moderate to severe disability due to cognitive sequelae. So, role of corticosteroids in viral encephalitis. We know that corticosteroids modulate both acute and chronic inflammation. They suppress pro-inflammatory signaling pathways. However, in HSV encephalitis, we don't have much evidence. It is being used at multiple centers at clinicians' discretion as and when needed. Also, there is a concern that use of corticosteroids can result in uncontrolled viral replication and worse outcomes. We also have to note that HSV encephalitis is similar in presentation with autoimmune encephalitis, and autoimmune encephalitis needs early corticosteroids as treatment, but it can be delayed until HSV PCR is negative, until HSV is ruled out. So what all prior data do we have? we have very much less evidence until now. There is a retrospective study with 45 participants where they studied the factors associated with worse outcomes in HSV encephalitis. Those were lack of corticosteroid use, older age, and lower admission GCS. And apart from this, we have only one RCT previously that is called as Gaucher trial. This included only 41 patients. The trial had to be terminated early due to poor recruitment. Here they had compared dexamethasone versus placebo in addition to acyclovir. But as it was terminated early, the results were inconclusive. There was no significant difference in 6-month functional outcome of whatever patients they had studied. So coming to our study, the PICOT statement of this trial will be population adults with confirmed HSV encephalitis receiving acyclovir are included. Intervention is adjunctive dexamethasone in addition to standard antiviral therapy. The comparison group would be standard antiviral therapy, that is acyclovir therapy. Outcomes, the main primary outcome is verbal memory score, which is by Wechsler's memory scale 4, auditory memory index. There are also many secondary outcomes like other cognitive domains, functional outcomes, mortality and safety outcomes, and imaging outcomes. The main follow-up duration for primary outcome was 26 weeks, and for secondary outcomes, it was 26 and 78 weeks. So the study hypothesis was that adjunctive treatment of dexamethasone, when added to standard antiviral therapy, improved functional neurological outcomes in HSV encephalitis compared with antiviral therapy alone, without increasing viral replication or adverse events. So coming to methodology, this was a multi-center randomized controlled observer blind phase 3 trial. It was conducted in 53 National Health Service hospitals in the UK. It was conducted between September 22, 2016 and February 2, 2022. And it was registered with International Standard Randomized Control Trial Number Registry. So funding was by NIHR Efficacy and Mechanism Evaluation Program for Department of Health. They had no role in the study design, data collection, analysis, interpretation, or writing. And ethics approval was obtained from UK National Research Ethics Committee. The protocol was also published, as we can see here. So the inclusion criteria included suspected encephalitis criteria defined as new onset seizure or new focal neurological deficits or alteration in consciousness, cognition, personality, or behavior. A positive HSV PCR result from CSF reported not more than 7 days prior to randomization. Patients receiving IV acyclovir dosed at 10 mg per kg TDS or at a reduced dose if clinically indicated, age more than or equal to 16 years, and written informed consent by the patient or their legal representative. Exclusion criteria included consumption of oral or injectable corticosteroid therapy in the 30 days prior to the day of admission, any hypersensitivity to corticosteroids, pre-existing indwelling cerebroventricular drain or shunt, peptic ulcer disease in the last 6 months, defined as a peptic ulcer seen at endoscopy or an upper GI bleeding, causing more than or equal to 2 unit hemoglobin drop in the last 6 months, antiretroviral regime containing rilpivirine as current treatment. This one is because dexamethasone is a CYP3A4 inducer, whereas rilpivirine is metabolized by CYP3A4 metabolism. So if they are given together, the drug levels of rilpivirine might come down and it might affect the efficacy. That is why that is also an exclusion criteria. Then immunosuppression secondary to any known HIV infection and CD4 count less than 200 cells by millimeter. But if CD4 count is more than 200, they are included. And patients currently on any biological or immunosuppressive agents, including azathioprine, methotrexate, or cyclosporin, any previous solid organ transplant or currently on immunosuppression, previous bone marrow transplant, currently undergoing any chemotherapy or radiotherapy, any known primary immunodeficiency syndromes, or known current hematological malignancy. So randomization, patients were randomly allocated in the ratio 1:1 to receive either dexamethasone plus acyclovir in dexamethasone group or only acyclovir in the control group. So they used minimization algorithm to minimize the imbalances across characteristics known to be associated with worse outcome in HSV encephalitis. In previous studies, they have found out that older age, steroid use and delayed steroid use and hospital admission, GCS or delay, lower GCS or delay in acyclovir administration are associated with poor outcomes. So minimization algorithm was used to imbalance these known characteristics. The algorithm checking was done by statisticians not otherwise involved in the trial. I would like to discuss about what is minimization algorithm. We will discuss it with an example. We choose key prognostic variables. For example, whether age is less than 60 or more than 60, GCS less than 8 or more than 8, time to acyclovir is less than 24 hours or more than 24 hours. These are the examples. So the first few patients are allocated by simple randomization in 1:1 ratio. Then after first few patients, for the next patient, now we imagine putting the patient in a group A. Now we calculate how imbalanced the groups would become. Then we will imagine putting the patient in group B and again calculate the imbalance again. Now we will assign the patient to the group with less imbalance. This will be done with a random element, that is even the probability of the patient going into the group with less imbalance is also 80%. 80% chance to the better group and 20% to the other. This is an example to prevent any predictability. So when is it used? It is used, it is an adaptive method of randomization used in clinical trials. It minimizes imbalance between groups for important baseline characteristics or prognostic variables. It usually includes a random element to prevent predictability. It is used when the sample size is small or moderate and when there are multiple factors which are going to affect the prognosis or outcome is strongly influenced by baseline characteristics. This is a software-based algorithm. Coming to masking, the neuropsychologist who will be assessing the primary outcome data and the other outcome assessors like radiologists, statisticians, and lead investigators were masked to randomization, whereas the trial participants, local site study teams, and trial data manager, they were aware of the randomization. Coming to procedure, all patients, they received intravenous acyclovir 10 mg per kg TDS or appropriate reduced dosage according to renal function for a minimum of 14 days. Then patients receiving acyclovir were randomly assigned to treatment groups within 7 days of initial lumbar puncture. And once they are randomized, if they are randomized to intervention group, then within 24 hours of randomization, they would receive IV dexamethasone 10 mg 4 times daily for 4 days, that is 16 doses in total. The clinicians were free to modify or discontinue the dexamethasone regime at any stage when this was judged to be in the best interest of the patient. This was the trial protocol that they decided. Once they are enrolled into this randomized control trial based on inclusion and exclusion criteria, they had targeted 90 patients. We will discuss how the statistics was sample size was calculated further. They would be divided into intervention arm and non-intervention arm, including 45 patients each. And intervention arm receiving dexamethasone 10 mg 4 times daily for 4 days plus standard care, that is acyclovir, whereas non-intervention arm standard care only, that is acyclovir. And baseline data would be collected during admission in the form of MRI, blood and CSF sampling and other data collection. And at day 14, MRI, blood and CSF sampling is repeated. And at day 30 or the day of discharge, disability and functional outcome scores, Addenbrooke cognitive examination and other data collection are done. Then first follow-up would be at 26 weeks, where the primary outcome, that is verbal memory score, is assessed, and other secondary outcomes are also, the data are collected, and MRI scan blood sampling is also repeated. And again, next follow-up would be at 78 weeks, where neuropsychological assessment for other cognitive domains apart from verbal memory score was done. Then disability and functional outcome score, MRI scan, and quality of health, life and health status questionnaire data was collected. So lumbar puncture was repeated after 14 days, and HSV 1 or type 1 or 2 DNA, if they are detected after 14 days, then acyclovir was continued with weekly lumbar punctures until CSF was HSV-PCR negative. Side by side, NMDAR antibody testing was also done with live cell-based assay. This testing was done at 3 levels. One is baseline in serum and CSF, second one at 2 weeks in serum and CSF, and third at 26 weeks in serum only. Coming to outcomes, the primary outcome was verbal memory score as determined by Wechsler Memory Scale Auditory Memory Index at 28 weeks after randomization. The secondary outcomes would be neuropsychological outcomes at 26 and 28 weeks, including memory, processing speed and working memory, language, executive function, and mood in the form of Beck's Depression and Anxiety Index, and other cognitive information with ACE-3 questionnaire at 30 days or discharge at 26 and 78 weeks. Then clinical outcomes included frequency of seizures at 78 weeks, time to hospital discharge, HDU or ITU requirement within 30 days, ventilator-free survival within 14 days, time to maximum GCS, all-cause mortality at 78 weeks. Then health status and quality of life was assessed at 26 and 78 weeks as measured by Euro Quality of Life 5D 5-Will Index and SF36 self-completed questionnaires. And disability and functional outcomes were assessed at 30 days or discharge at 26 weeks and 78 weeks with MRS, Barthel Index, Liverpool Outcome Score, and Glasgow Outcome Score extended at 26 weeks. Imaging outcomes included change in temporal lobe volume, change in whole brain volume, change in flare lesion volume, that is edema, and change in diffusion restricted lesion volume. This was collected at baseline, week 2, week 26, and 78 weeks. Safety outcomes in the form of proportion of patients with detectable HSV in CSF by PCR at 2 weeks. And exploratory outcome in the form of NMDAR antibody testing in CSF and serum at baseline and 2 weeks and only in serum at 26 weeks. So the sample size estimation, they expected mean verbal memory score to be 88.9 and allowing for a expected 10% mortality rate and adjusting to the population mean, it was considered to be 84.8. The clinically meaningful difference, which would cause some clinical benefit, was 15.5 points. So adjusted to 80% power and two-sided alpha of 0.05, the sample size was estimated to be 36. And expecting a 20% dropout, the final target sample size was 45% participants per group. So statistical analysis, they have analyzed with modified intention to treat analysis. The primary outcome score, that is auditory memory index, was taken at 26 weeks was analyzed with linear regression or ENCOVA framework. It was adjusted for pre-specified minimization factors like age, steroid use since hospital admission, or hospital admission GCS score, or delay in the acyclovir treatment. All analysis was conducted using SAS software version 9.4. So secondary outcome analysis, cognitive and psychiatric outcomes were analyzed with linear regression, time to event outcomes with Kaplan-Meier curves, binary outcomes with logistic regression, the incidence of epilepsy, HDU or ITU admission, mortality, HSV PCR positivity at 2 weeks. Then missing data was managed with multiple imputation, and post-hoc analysis was done with regression. They explored timing of dexamethasone initiation versus verbal memory outcome. So once the patients were, first the patients were assessed for eligibility. 1,274 patients were not eligible and 59 patients did not consent. Then 94 patients were randomly assigned with 47 patients to each, the dexamethasone group and control group. In dexamethasone group, 46 patients received dexamethasone and 1 did not receive. And they have not mentioned why they did not receive. It was decided that clinician would decide whether to continue or not based on the patient's condition. Then 47 were assigned to control group where 43 did not receive dexamethasone as per the control protocol and 4 received dexamethasone in first 30 days. Then in dexamethasone group, 4 withdrew before primary outcome assessment and 4 were lost to follow-up, whereas in control group, 3 withdrew before primary outcome assessment and 2 were lost to follow-up. So in DEXA group, 33 completed the primary outcome assessment, whereas 4 died before primary outcome assessment and 2 were too ill to complete the primary outcome. Whereas in the control group, 33 completed the primary assessment, 4 died and 5 were too ill to complete the primary outcome. However, the people who were too ill to complete or the people who died before assessment, they were given the minimal score. So totally 39 patients were included in primary analysis in the dexamethasone group and 42 patients were included in primary analysis in the control group. So coming to results, baseline characteristics like mean age and gender distribution, ethnicity distribution was similar across both the groups. Mean age was 64 in DEXA group and 67 in the control group. And even the stratification factors which were known to affect the prognosis like age, disease score, steroid use since admission and delay in receiving acyclovir, they were also similar across both the groups. Then other clinical factors like days from hospital admission to randomization, whether they are receiving intensive therapy unit treatment or any whether ventilator support is needed on day of randomization, these data were also similar across both the groups. And CSF PCR results in DEXA group, 41 were HSV1 positive and 6 were HSV2 positive, whereas in control group, all of them were HSV1 positive. The most common symptoms across both the groups were also similar. It was fever, followed by headache, seizures, dysphagia, and photophobia, neck stiffness, or signs of meningism. So coming to primary outcome, the primary outcome, that is verbal memory score, in dexamethasone group was 71, whereas in the control group was 69. The adjusted difference was plus 1.77 with a wide confidence interval of minus 9.57 to plus 13.12 with a p-value of 0.76. There was no statistical significance in the primary outcome. The death of 8 patients, that is 4 per group, was directly attributed to encephalitis, and 7 patients, including 2 in the dexamethasone group, had severe neurological sequelae. They were unable to complete primary outcome assessment. And all these death patients plus 7 patients who were not able to complete primary outcome assessment, they were attributed to lowest verbal memory score as decided previously. Coming to secondary outcomes, neuropsychological and cognitive outcomes, including visual memory, immediate memory, delayed memory, working memory, and processing speed, all of them were similar across both the groups, and there was no statistical significance. Even the ACE3 questionnaire, the score was 32 and 28. There was no statistical significance between both the groups. Then clinical outcomes, including all-cause mortality, frequency of seizure at 78-week visit, time to hospital discharge, or requirement of ITU or HDU after randomization. All of them is similar across both the groups with no statistical significance. Even the quality of life outcomes at 26 weeks, including SF36 questionnaire or EQ-5D-5L assessment, that was also similar across both the groups. So clinical outcomes, these are the Kaplan-Meier curves showing the clinical outcomes. First one is time to hospital discharge. The blue colored line is dexamethasone group and the red colored line is control group. We can see that the shaded color in the light red and light blue color, they represent the confidence interval. We can see that the confidence intervals are very wide and they're overlapping with each other. And even the lines, blue and red lines, are overlapping with each other. So there was no significant difference whether we take time to hospital discharge or time to reach hospital, time to reach 14 days without any ventilator support. A similar result was also seen in time to reach maximum recorded GCS or survival. We can see that the confidence intervals are very wide and the lines are overlapping between each other. The functional outcomes, including Glasgow outcome score extended at 26-week visit and 78 weeks. They also were similar across both the groups at both 26 and 78 visits. Even other scores like MRS, Bartle index, they were also similar across both the groups without any statistical significance. Coming to imaging outcomes, even though they had decided on multiple volumetric analysis, only few could be done. They have mentioned that due to COVID-19, they could not do proper imaging outcome follow-up at pre-specified time duration. Only two outcomes were reported in imaging outcomes. One is change in temporal lobe volume. We can see here the x-axis represents the time duration. First part is 0 to 2 weeks and second part is 0 to 26 weeks, and y-axis shows temporal lobe volume change in the form of percentage. Then the light yellow dots represent individual patients in the control group, and dark blue dots represent individual patients in the dexamethasone group. And this horizontal line at 0 line, what we are seeing, the darkly marked line, this represents the mean. So we can see that from baseline to 2 weeks, in temporal lobe volume, there was reduction in the control group of 0.1%, and there was mild increase in dexamethasone group of 0.2%. The adjusted difference was minus 0.21. There was no statistical significance. Even at 26 weeks, the change in temporal lobe volume was similar. In both, it was reduced by 0.6% in both control and dexamethasone group, and the adjusted difference was 0.42 without any statistical significance. So similarly, this graph represents change in edema volume from baseline to 2 weeks with respect to total edema, cytotoxic edema, and vasogenic edema. Across both the control and dexamethasone group, the change was similar, with adjusted estimates being minus 0.31 in total edema, 0.14 in cytotoxic edema, and minus 1.83 in vasogenic edema, with wide confidence interval. Again, none of them were significant. So coming to patients with relapse, they have reported that 5 patients have relapsed, and all of them belong to dexamethasone group. The individual patients, they relapsed at different time periods. One relapsed at 16 weeks, 24 weeks, 52, and 12 weeks. And all of them were HSV PCR negative at 2 weeks duration. That is in the CSF, which was done at 14 days. And NMDAR antibody was positive in serum in one patient, that is the one in the last row. And NMDAR antibody in CSF was positive in 2 patients, the last 2 ones. So they were treated differently. Most of them were, 3 of them were treated with oral steroids and discharged, and 2 of them were treated with acyclovir. Coming to adverse events, the neuropsychiatric disorders, that was taken as one of the adverse event. It was similar across both the groups. It included seizure, headache, development of autoimmune encephalitis or meningoencephalitis, cognitive disorder, hepatic encephalopathy. All of them are similar across both the groups. Then even the thrombotic disorders, that also did not have any significant difference across the 2 groups. Also, infections or other metabolic or general adverse effects like acute kidney injury, dehydration, or fall, they also did not have any much difference across both the groups. Post hoc analysis was done to study the effect of delay in administration of dexamethasone on primary outcome. Here we can see that in x-axis they have represented days from hospital admission to first dose of dexamethasone, whereas in y-axis they have represented verbal memory score. We can see that there is a regression in this score from the beginning to end. That is, longer time to dexamethasone initiation was associated with a reduced verbal memory score. Verbal memory score decreased by an adjusted estimate of 4.89 points for every day of delay in starting the drug. This was significant with p-value of less than 0.0001. This was the only positive outcome which they have reported in the study. Coming to discussion, primary outcome, adding dexamethasone to acyclovir did not improve verbal memory score at 28 weeks in adults with HSV encephalitis. And even at long term, there was no significant differences at 78 weeks in verbal memory or other neuropsychological measures, functional status, or even imaging outcomes. Regarding safety, dexamethasone was safe, there was no increased HSV PCR positivity in CSF at 2 weeks, suggesting there was no impairment of viral clearance. Coming to discussion of adverse events, they were similar between both dexamethasone and control groups. 5 clinical relapse occurred all in dexamethasone group. None of them showed HSV PCR positivity, making virological relapse unlikely. Then exploratory post-hoc analysis, they have reported that earlier dexamethasone administration may be associated with better outcomes, but many patients received steroids late, so limiting definitive conclusions of the same. The advantages of this trial was it was an open label observer blind design, which was logistically simpler. Then they have used verbal memory as the primary outcome. This was a disease-specific outcome instead of MRS, which was checked in prior RCTs or studies. Then the dose rationale. They have used 10 mg dexamethasone 4 times daily for 4 days. This mirrored regimens effective in bacterial and tuberculous meningitis rather than higher dosages as used in autoimmune encephalitis. Broader implication is that corticosteroids do not worsen HSV encephalitis. And earlier steroid use in undifferentiated encephalitis before HSV PCR might not cause any harm. So this was the viral replication that they had put up in the supplementary article. Here we can see that at 2 weeks, detectable HSV PCR positivity was 9 in control group and 4 in the dexamethasone group. The adjusted odds ratio was 0.47 and there was no statistical significance. Coming to critical appraisal, we will be discussing in the following headings according to CASP checklist regarding study design and validity, methodology, results, and applicability. So, did the study address a clearly formulated research question? Yes, we have seen and discussed it in detail. PICOT also we have discussed in detail. Is the study design adequate? The study was a multi-center observer-blind randomized phase 3 control trial, but a double-blinded placebo-controlled RCT would have been better compared to only observer-blind trial. How was the randomization carried out? It was a central, secure, web-based randomization. Allocation ratio was 1:1, and they have used a minimization algorithm with a random element. So was the allocation concealed from investigators and participants? Yes, a central, secure, web-based system. It prevented any prediction of allocation. Was the randomization sufficient to eliminate any bias? No, because there was performance bias because participants and clinicians were not blinded. And there was significant attrition bias. There were so many withdrawals and loss to follow-up. And modified ITT was used. Contamination bias was also there because some control patients received dexamethasone as per clinician discretion as needed. This would have diluted the treatment effect. Were all the patients who entered the study accounted for at conclusion? Yes, largely modified ITT was done. 81 were included. Total randomized was 94. 7 withdrew consent and 6 were lost to follow-up. Even the patients with death and participants too ill to compete were included in primary outcome. They were assigned the lowest score of 40. So regarding blinding, it was an observer blind trial. It was not double blinded and no placebo was used. Were the group similar at the start of RCT? Yes, they were largely similar as we saw in the baseline characteristics. Was there a clearly defined study protocol? Yes, it was clearly defined and the protocol was also published, which is available. Were the effects of intervention reported comprehensively? Yes, we have discussed outcomes comprehensively. Primary outcome was there and multiple secondary outcome including cognitive, neuropsychological, safety, mortality were all discussed in detail. Was the power calculation undertaken? Yes, the sample size was precisely calculated as we discussed earlier. Were the results reported for each outcome in each study group at each follow-up interval? Yes, it was reported. Was there any missing or incomplete data? Yes, 13 out of 94 withdrew consent or were lost to follow-up. 15 out of 94 they died or were too ill to complete primary assessment, although they were included in modified ITT by assigning the lowest score. So are these participants similar to people in our care? Yes, we also see a lot of HSV encephalitis patients. They are similar. Would any differences between your population and study participants alter the outcomes reported in the study? Yes, there are some racial and ethnicity differences. This was conducted in UK, where Indian population were not at all included. Are there any limitations of the study that would affect your decision? Yes, there are some limitations. The study was powered for primary outcome. They have calculated the sample size adequately. But for secondary outcomes, the study was underpowered. Also, the recruitment was paused during COVID-19 pandemic. However, they have reported that they have collected all psychological data, and they have completed the assessments remotely as per British Psychological Society guidelines. Also, sample size was limited for subgroup analysis like racial or ethnic groups. And there were some protocol deviations, but sensitivity analysis later also showed no impact on the primary outcome. So the take-home message would be adjunctive dexamethasone usage in HSV encephalitis did not improve any cognitive or functional outcomes overall, but it might be safe with a possible signal that if earlier initiation of dexamethasone might be beneficial. It opens the possibility of safe and earlier steroid use in undifferentiated encephalitis, like if the patient is coming with features similar to autoimmune encephalitis, even before HSV PCR results are available. Thank you.
Okay, thanks a lot, Tripti. That was a fantastic presentation, very detailed and well summarized. So I just wanted to ask, if it's possible to ask the attendees, does anyone use steroids for herpes encephalitis in clinical practice? And if so, then what scenarios would be, because here they have just used it for all patients once they are diagnosed. But do we stratify patients usually? If anyone uses steroids, it would be interesting to hear from the attendees. Maybe Angel, you can start, and maybe we can have some comments in the chat box.
Yeah, so thanks, Dr. Trupti. That was a wonderful presentation and an appraisal of the trial. So it's always a dilemma because if you actually look at the pooled evidence for HSV encephalitis, there are some studies which actually say steroids cause harm. Because your body's humoral immune response and the cell-mediated response gets suppressed, which is very essential to control the viral replication. So that's the theory behind it. They say it will lead to unchecked viral replication, causing more harm than good. However, there are some studies which actually say that it's all the damage which occurs with HSV encephalitis is because of the inflammatory storm or the cytokine storm, which secondary cascades it triggers, and that actually steroids, if you hit them, it limits disability. So the evidence is still very divided, and this is one of the very few. I mean, doing an RCT for this condition is very difficult. So, because we know that getting a HSV diagnosis with PCR itself is a limited thing. Most of us go clinically and radiologically, not wait for the PCR. So in that way, yeah, of course we can take this, but at least one thing is it's not harmful. There is no harm, like as told in previous studies that it can lead to unchecked viral replication. So it might be an individualized decision, seeing the extent of damage in the brain, clinical condition, where if you feel it is more severe, we could still consider a short course, like how we give for pyogenic meningitis. So, and that's what we do here as well. So in patients presenting severe seizures, encephalitic syndrome, you hit them hard with whatever possible, like acyclovir, and sometimes we do give steroids if they have a meningeal response.
We agreed. Often empirically, steroids are given, and yeah, but it was. I guess we're getting a few comments now. Let's see. So, was this trial adequately powered to detect differences across clinically important subgroups such as early versus late steroid initiation, HSV1 versus HSV2, and disease severity? So, I mean, so they have looked at. They did not stratify it according to these things, but they have looked at it in the analysis. So HSV1 versus HSV2, there was very limited numbers. So in the DEXA group, we had, I think they had 41 patients with HSV1 and 6 with HSV2, and in the control, all were HSV1. Now, the HSV2 thing is, it's a good question, and we were also wondering about this. So HSV2, as we know, it can cause really severe disease in immunocompromised individuals, neonates particularly, and elderly. However, they have clarified in the article that HSV2 that was taken here, all those patients were immunocompetent. So probably it did not make too much of a difference, but they did not separately analyze the HSV2 6 patients vis-a-vis the rest of it. Early versus late steroid initiation, yes, they have definitely looked at it. One of the concerns that we had while going through this trial was that they haven't really looked at the time to steroid initiation from the time of illness onset, like or symptom onset. They have looked at the time of initiation of steroids rather from the time that the person gets from admission to recruitment. That's the timeline we have. They haven't explicitly mentioned at what duration. They have mentioned rather from the time that the patient is recruited into the trial after this thing. So we can use that as a proxy. That is okay. But what they did find is that not specifically for steroids, and this is a really good question. What they found was that the earlier into the study the steroids were administered, the better seemed to be the outcomes. And here again, I would like to mention that the patients that they have taken are all PCR positive. So that was the point of recruitment. You understand? So the diagnosis is made based on PCR positivity. It is not pragmatic in the sense that a patient comes in with an acute meningoencephalitis syndrome and we give off the steroids. Here they have waited for the HSV PCR to come positive and then they have started the steroids. So that has definitely led to a little bit of delay in initiating the steroids. This also raises pragmatic concerns for our country, I mean, our scenario as well, because we do know that PCR turnaround time can vary. At our center, it can be more than several days. In other centers, it may be quicker. So definitely, if we take HSV PCR positivity as the point of entry for steroid, the steroids administration, then this trial doesn't answer that part. This is a very important question that has been raised, I think. And disease severity, I think, Tripti, any comments on disease severity, whether they have looked at this part? I mean, they looked at the
Yes,
functional
ma'am. They
outcomes,
have looked
definitely.
at it.
Yeah.
That was looked in the form of secondary outcomes.
Yes. Yeah.
How long they took for discharge, whether they needed any IT or HDO admission, or whether they needed any ventilatory support. Indirectly, they have
Yes.
looked at in this way.
Yes. 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 So that was the markers, basically, whether the patient was ventilated or not, and things like that. The other question is, if we will use DEXA, what is the dose? So what they have done is that they have used exactly the same dose, so 10 milligrams, for just as we use for bacterial meningitis, QID for 4 days. That is what they have done. So I'm not sure whether that would directly be applicable, but if we were to take the pathophysiology, as Angel had also said in the beginning, then maybe this dose is appropriate. And actually, they have taken the dose from the previous trial that was there, the Gashi trial that Tripti had mentioned earlier, which is the dose they had used. So they just used that and looked at it. What is the turnaround time for HSV PCR in general, like for you all?
So in our center, we do it twice a week. So the runs happen on Wednesdays and Fridays. So
Yeah.
if your patient happens to come over the weekend, the earliest we can get is Wednesday.
Yeah.
So, but the take-home point is among all the viral encephalitis, this is the only virus which actually responds to acyclovir.
Correct.
So that is another take-home point where I think more than steroids, it's worthwhile to prioritize it empirically. Don't wait for the multiplex to come. We'd
Agreed.
rather
Yes.
treat and Also, Trupti, it was quite interesting to see the presentation, like the relapsed cases, no? That's another
Yes,
point
ma'am.
to note. HSV for some reason triggers NMDAR. And in fact, you said how many of them? Three of them.
Two of them were positive for NMDAR. Total five of them have relapsed, ma'am.
Yeah.
Among them, two were positive.
Positive. So that it's a big number, actually, 2 out of 5. So that's another important point to take. Somebody who's managed to, get over HSV, it's important to keep following them up also, because suddenly they have worsening thing, then it's worsening seizures, worsening cognition. That is one important thing to consider, because this is again a potentially treatable condition, and which will respond very well to steroids.
And just going along that exactly on that vein, just taking it a little further. So it is recommended for in terms of the treatment that you repeat an HSV PCR and then actually treat them if it continues to be possible. So usually we would give acyclovir for an adult immunocompetent person for around 14 days. So actually, as per the guidelines, one should repeat a CSF HSV PCR. And if it is negative, then the treatment can be discontinued. If not, you continue it till it becomes negative. This is what they've also done in the trial. So it is also important to, I think, do this because when a patient comes in with a relapse, it could be either related to reactivation of the herpes encephalitis itself, or it could be an autoimmune encephalitis, so typically an MDA receptor encephalitis. If you have a baseline positivity, positive becoming negative while it's on treatment, later on when the person comes with relapse, if you do an HSV PCR, it would be nice to know whether it is negative. And if it is negative, you can be very confident that this is more likely to be immune-mediated encephalitis than it is likely to be a viral relapse. This has also matter of concern. Earlier you to be previously with relapse probably had mediated encephalitis.
All right. So, yeah, so if there are no further questions, there's one more. If we use DEXA, what is the dose and duration? Is it same as that of bacterial meningitis? So, in this trial, they've actually used, I think, Trupti can.
Same,
Yeah.
10
class,
mg,
yeah.
10 mg 4 times daily for 4 days. So total
Yeah.
16 doses.
So in this trial, they've used the same bacterial meningitis
Yes.
protocol.
Yeah, they have
But
extrapolated from the older data of the same thing.
yeah. So what we do is, when we are in doubt, we actually are on the lower side of DEXA, because previously, just based on the sheer evidence that this can cause harm, but now we are actually giving confidently 10 mg Q6H after this trial, because it's safe, so it doesn't cause any harm. But of course, the sample size is small. They're not our population. These are the things which we have to take it with a pinch of salt. But I think, because it's the only level A or class A evidence which is available, we go by it. Okay.
Yeah, I think there are no further questions.
Yeah. There are no further questions. Oh, one more. Okay. The relapse data combines HAV and NMDA.
Yeah.
What is your take on it? Yeah.
It's a very good question. And really, to be honest with you, I had a lot of heartburn when they showed the relapse table in the paper, because they've actually clubbed the relapses. Trupti, you can just share that. We can just show that once. What has happened is that if you look at this table, there is some lack of clarity in the table, because some of them are definitely seeming to be NMDA receptor encephalitis, but then there are others where it is not clear whether it is a herpetic relapse or it is an MD encephalitis. And if you look at the treatment and the outcomes also, then those are not very clearly given. So, for example, if you look at case number 3, so it's written treated with immune therapy. Case number 4, written treated with acyclovir, no response to treatment. This combination of things, I think it's a little, I think it's a very pragmatic table that they have shown, because clinically sometimes we also don't have all the information. Somebody's HSP-PCR was not done at follow-up. Somebody's serum is missing. Someone's CSF is missing. If you look at the table, it's actually exactly like that. Some samples are there, some are not there. I think, however, having said that, clinically, I think it's really important, like we have been discussing earlier, to look at the relapse from the point of view of it is likely to be immune mediated or it is likely to be a viral relapse. And there, it is clinically very difficult sometimes to distinguish this versus this. Radiology may give some clues, but sometimes even that is not very useful. But the thing that helps is actually the HSV PCR. So if you have a baseline that has become negative and then you get it coming positive when the patient comes with relapse, it can be really useful, because otherwise what might end up happening is that the patient gets acyclovir course and then also gets methylprednisolone. So you cover the acute period, but later on you're left wondering, now, do I continue with the immune therapy or not? So I think that is the message from the relapse table.
Okay, so yeah, so that brings us to the end of this webinar. So thank you, Dr. Divyani and Dr. Trupti, for putting in this together, and it makes a lot of sense. So all these videos will be uploaded in our YouTube channel, so you can subscribe to Climb India ICMR. So all the previous webinars will also be loaded there. So if anyone has missed it, you can have a look. So our next webinar is on May 5th. We'll listen to insights from Central India on brain infections. So we'll catch up there. Thank you. Good evening to all.
Thank you. Thanks, Angel. Thanks, Tripti. Bye.